Assalamu alaikum. Good day to all of you, dear doctors. Today, I'd like to share a brief discussion on about gastric outlet obstruction, which is an important topic for both part of MRCS examinations. Here's the stem is a lady with non-venous vomiting and epigastric fullness. Here's hyponatremia and lab investigation shows hyponatremia and hypokalemia and hypochloremia and pH is 7.6. Here's the question is what does ABG and lab investigation shows that pH is high and bicarbonate high and normal partial pressure of oxygen and partial pressure of carbon dioxide. The electrolyte imbalance are hypochloremia, hypokalemia, hyponatremia, and uncompensated metabolic alkalosis. The standard pathophysiology of gastric outlet obstruction is non-venous vomiting due to obstruction at gastroduodenal junction, either due to fibrosis after peptic ulcer or malignancy, or external compression mass and loss of hydrochloric acid and potassium. It occurs due to benign cause such as pyloric stenosis, which is secondary due to chronic peptic ulcerations, and gastric and pancreatic carcinoma. As arterial blood gas analysis shows metabolic alkalosis and biochemical abnormalities found such as hypochloremia occurs due to loss of chloride ion in vomiting or loss of food due to hydrogen ion, and hypokalemia occurs due to increased aldosterone in response to hypovolemia, and first hyponatremia occurs due to in case of metabolic alkalosis, kidneys excrete more sodium bicarbonate to reduce blood alkalinity. So here's hyponatremia occurs. Next, why bicarbonate is increased? Actually, there will be increased uptake of bicarbonates in renal tubules in response to loss of chloride in order to maintain electrochemical neutrality, and due to reduction of pancreatic juice secretion due to loss of acid load in the duodenum, and retention of bicarbonate-rich pancreatic juice occurs. As a result, the patients profuse vomiting. They have lost significant amount of hydrochloric acid, such as stomach acid parietal cells, then produce more carbonic acid in response, and the hydrogen ions are then transported to stomach to reduce what was lost. The remaining bicarbonate is transported into the blood and resulting in an increased free bicarbonate. As a result, bicarbonate is increased. In addition, as a result of vomiting, the patient's volume is depleted, which results in the release of aldosterone and other mineralocorticoids, which in turn increase bicarbonate reabsorption by the kidneys. Why got paradoxical aciduria? Paradoxical aciduria occurs due to the due to stimulation of renin-angiotensin and aldosterone system. More sodium and water are reabsorbed in exchange of hydrogen and potassium ion. As a result, hypokalemia occurs and the urine becomes more acidic due to presence of hydrogen ion. Thus, the creatinine and urea are high due to hypovolemia. As a result, renal hypoperfusion occurs. Then acute kidney injury occurs here. Now the symptoms here to us about the cardiac arrhythmia, renal function and respiration, fasting and dehydration, visible peristalsis to avoid paralytic areas. Succussion is flush is found. Succussion is flush like sound heard over the stomach in the left upper quadrant of the abdomen on shaking the patient with or without the stethoscope. Bowel sound may be increased due to excessive peristaltic action of stomach. Fullness in the left hypochondria may also be present. As the classifications of hyponatremia are urine with high sodium ion or has greater than 20 millimole per liter, and urine sodium low chances less than 20 millimole per liter. High sodium found in due to excessive diuretics use and salt losing renal disease, mineralocorticoid deficiency. That's the extracellular fluid volume is low, but in case of extracellular volume, normal or highly raised in glucocorticoid deficiency and hypothyroidism and syndrome of inappropriate antidiuretic hormone and extracellular fluid volume highs are found in case of renal dysfunction. Urine sodium low found due to extrarenal loss and out with body sequestrations and dilational such as intravenous 5% dextrose and water injections in case of cirrhosis of liver and in case of cardiac failure and in case of nephrotic syndrome. Now we'd like to share about the complications of hyponatremia. It depends on the degree. It includes confusion, lethargy, muscle weakness, cramps, seizures, cerebral edema, cardiopulmonary arrest, coma, and even finally death. Now I would like to share a brief discussion on how you treat these patients or will should be involved in management of consent for laparotomy. What's the treatment? It begins today with CD resuscitations and high flow oxygens, normal saline and potassium supplementations for resuscitation plus monitoring and central venous pressure insertion and nothing by mouth and patient position is upright position, gastric suction to avoid aspiration. Here's the contract senior and try to investigations needed such as blood imaging and endoscopy. Correct fluid deficit with IV hydration and potassium supplementation in fluid regimen. Strict input and output charging and endoscopy or dilation. Most common surgical procedures performed in case of gastric outlet obstruction related to peptic ulcer disease are vagotomy and antrectomy, vagotomy and pyloroplasty, and truncal vagotomy and gastrojejunostomy. This is done after taking consent of a patient party. That's all about today about the gastric outlet obstructions. If you have further questions, contact us or feel free to ask me. Thanks all of you for watching my videos. Good day to all of you, dear doctors.